I believe my task is doubly unenviable. Firstly, because I am following up such great speakers and such wonderful talks. And the second, obviously, the Hyderabadi biryani, which you have enjoyed for lunch. So I will try to keep the talk short and crisp and introduce you to overlap syndromes over the next 20 minutes. And so, what is overlap syndrome? So, overlap syndrome is a very generic term which is used in different specialities, in various specialties of medicine. But when we talk about sleep medicine, and particularly in the context of OSA, the term overlap syndrome has been used most classically for the OSA COPD overlap syndrome. And this terminology was given by Flenley et al. In the 1980s. Since then, there has been an attempt by people to use the term overlap syndrome for other chronic respiratory disorders which may occur in combination with OSA, such as OSA asthma and OSA ILD. And I acknowledge here that these are, of course, very important overlaps, and they have bidirectional, OSA has bidirectional relationships with these other chronic respiratory disorders and affects their outcomes. However, given the paucity of time, today I will stick with the OSA COPD, which is the accepted overlap syndrome in literature. And one caveat I will tell you at the very outset of the talk is that COPD with OSA is only the tip of the iceberg, and COPD has sleep disordered breathing in other forms as well. In fact, sleep linked hypoventilation in COPD may be more common than COPD OSA overlap syndrome. So, coming to overlap syndrome of OSA and COPD, how common is it? So, we both know that OSA and COPD are both very common disorders, and about 10% of the general population has OSA, 10% of the general population has COPD, give or take a few in the adults. However, given the commonality of both the disorders, if we just go by statistical probability, so 10% into 10% is equal to 1%. So that is the expected prevalence of overlap syndrome if it were to occur by chance alone as an overlap. And in fact, that is what we have found in various studies, that the prevalence of overlap syndrome in the general population is between 1 to 3%. Why is this so? Why is this happening just by chance? Is there any way OSA is COPD is affecting the prevalence of OSA? We'll discuss about that. But we do know that among patients with COPD, the prevalence of OSA ranges from 9 to 40%. It is highly variable. And why is that? Because COPD is a heterogeneous disease, and different presentations of COPD may either protect or increase the risk of OSA. So before we delve into that, let us see what are the sleep-related changes in normal individuals and how it is different in a patient with COPD. So we know in a normal person also, when you fall asleep, there are changes in the respiratory drive. There is a diminished drive from the higher centers, and there is also blunted chemosensitivity. Additionally, there is reduced activity of the non-diaphragm respiratory muscles, accessory muscles, and decreased pharyngeal muscle tone. All of these factors put together contribute to a mild degree of hypoventilation in sleep, which is inconsequential in a normal individual. But in a person with pre-existing chronic respiratory disorders, who are already on the steep portion of the oxygen dissociation curve with a lower baseline PaO2 value, any drop in the PaO2 further can be actually precipitous, can lead to precipitous hypoxemia. Additionally, patients with COPD are dependent on use of accessory muscles of respiration due to a mechanically disadvantaged diaphragm. And hence, the loss of activity of these accessory muscles particularly harms these patients of COPD, and these patients may also have instability of the upper airways. And all of these things put together lead to sleep-linked hypoventilation in COPD. So now I've talked about sleep-linked hypoventilation, but how does OSA come in? So we had heard in Professor Danny Eckert's talk about some of the factors which lead to development of OSA, the interaction between the anatomical as well as the physiological factors. So we know that the pharyngeal muscle activity, the dilator activity prevents the development of OSA, and additionally the lung expansion, when you have a large lung volume, you know that causes a caudal traction on the upper airway and prevents development of OSA. On the other hand, negative pressure during inspiration and extraluminal positive pressure due to fat or fluid or edema or a large tongue may lead to predisposing to development of obstructive sleep apnea. So as I mentioned, COPD is a heterogeneous disorder. There are factors which promote OSA, there are factors which are protective against OSA. Now, when we talk about COPD, sometimes it is helpful to think of them as an emphysematous phenotype, as a chronic bronchitis phenotype. So when we talk about a person with predominant emphysema, we know they have lung hyperinflation. Many of these patients are cachectic, have low BMI. So this hyperinflation, as I mentioned in my previous slide, this higher lung volume is actually preventive against upper airway collapse by having a caudal traction. So these are factors which protect against OSA, but not against sleep-linked hypoventilation. In fact, these patients are not able to go into REM sleep because they develop precipitous hypoventilation, and so what protects against OSA actually may lead to hypoventilation in these patients. On the other hand, you may have patients with milder COPD with predominantly chronic bronchitis phenotype. They may be heavy smokers, they may be obese, they may develop early onset of cor pulmonale, what we call as the blue bloaters. And these patients, because of their heart failure, they have pedal edema, which in the night moves to the neck. This rostral fluid shift results in more of OSA in these patients, as well as the cigarette smoking, the upper airway inflammation. The use of inhaled corticosteroids leads to upper airway myopathies, and all of these things may predispose to OSA in these patients. That is why we get the prevalence figure of OSA in COPD to vary between 9 to 40%. So what I can conclude so far is that in COPD there is a spectrum of sleep disordered breathing. 40% of COPD patients have some form of sleep disordered breathing. It may just be sleep-linked hypoxemia due to the VQ mismatch in the sleep, or it may be an OSA COPD overlap syndrome, or it may be sleep-linked hypoventilation, or it may be central sleep apnea. So central sleep apnea is something which is relatively unexplored in COPD, and the evidence for that is less, but definitely because of the congestive heart failure which may occur as a comorbidity in these patients, that is also something we need to look at. So the consequences of overlap syndrome, we know that OSA and COPD both lead to hypoxemia during sleep, but the type of hypoxemia is different. In OSA, you get intermittent hypoxemia, and in between the events, your saturation goes back to normal. In a way that is even more harmful, as we heard in previous talk, this intermittent hypoxemia leads to hyperoxia in between, and that may lead to more of oxidant stress and oxidant injury. On the other hand, in COPD, you get sleep-linked hypoventilation, which results in sustained hypoxemia, particularly during REM sleep. What we get in overlap syndrome is actually a kind of a double whammy. So there is this sustained hypoventilation leading to sustained hypoxemia during REM sleep, and on top of that you get this intermittent hypoxemia which is superimposed, and this is what results in a lower mean saturation during the night in overlap syndrome. They have more hypoxemia, which results in oxidative stress, in increased level of inflammatory markers like CRP, IL-6, IL-8, which we know result in endothelial dysfunction, development of atherosclerotic plaques, and cardiovascular disease. Hence, patients of overlap syndrome, when we compare to patients with either OSA alone or COPD alone, they have greater nocturnal hypoxemia, higher levels of pro-inflammatory mediators, and more burden of hypertension, diabetes, obesity, as well as pulmonary hypertension, cardiovascular events, and mortality. So this is one of the prospective studies between 2005-2008 which showed that patients who have overlap syndrome have the lowest survival, followed by those who have COPD alone, and OSA alone was comparatively better, and normal individuals was the best. So clinical features, Here, one thing I want to tell you very important is that patients of COPD may not come with typical symptoms of OSA even if they have OSA. The daytime sleepiness and snoring may not be the predominant symptom, rather they may present with daytime fatigue. The Epworth Sleepiness Score and the Berlin Questionnaire are not accurate at predicting OSA in COPD patients. However, even in the absence of daytime sleepiness, these patients have a reduced quality of life if OSA is a comorbidity in COPD. So what is important is you have to have a high suspicion of OSA among patients with COPD. And when do we perform a sleep study for overlap syndrome? So there is no formal guideline, I must admit that. But patients who have symptoms of OSA definitely go for it. Additionally, if a patient has daytime hypercapnia or nocturnal desaturation, this may be due to OSA, this may be due to sleep disordered breathing, sleep-linked hypoventilation. Additionally, a reduced a borderline desaturation or a desaturation during exercise, presence of complications of nocturnal hypoxemia like pulmonary hypertension or polycythemia. And also, interestingly, the American Thoracic Society has advised that we should also consider stop bank questionnaire, although stop bank questionnaire is something which is more of a pre-anesthetic kind of a screening questionnaire, but because in one of the post hoc analysis of the LOTT trial, the stop bank questionnaire was found to have some value in predicting OSA and COPD, so the guideline has suggested you can do that as well. So, which type of sleep study should be performed? Well, there is only one type of sleep study you should perform in a patient of COPD, and that is an in-lab study, and preferably with the non-invasive monitoring of carbon dioxide in the form of either a EtCO2 or a transcutaneous CO2. Home sleep apnea testing is not advisable in these patients as it does not pick up hypoventilation and it is not possible to perform titration. Autopap is not an ideal approach for overlap syndrome. I will tell you why in a couple of minutes. And overnight pulse oximetry can detect nocturnal desaturation, but it only has a role as a screening tool. So now let's talk about PAP therapy for overlap syndrome, the evidence and the pathophysiological basis. So we know PAP therapies, we know they are CPAP, there is BPAP, and in COPD there is also something known as high intensity NIV, which is essentially a form of BPAP in which we are trying to normalize the CO2 value by having a higher difference between EPAP and IPAP with a backup rate. So which one do you use? So again, it depends on COPD and sleep disordered breathing is not a uniform entity. It depends on what you're dealing with. So PAP is the mainstay for therapy of OSA, starting with CPAP. So if you have a patient with predominant OSA, you start with titration of PAP with a CPAP, and if you have a COPD patient with OSA, it should be done in a sleep lab. If the patient has features suggestive of hyperventilation, you may have to switch to a BPAP, and the initial titration protocol is same as that for OSA without COPD. The impact of therapy of PAP in overlap syndrome, what is the evidence? Well, the evidence is essentially from observational studies. It improves pro-inflammatory marker levels. It improves physiological outcomes like ABG, 6-minute walk test, PFTs, and it also improves heart clinical outcomes like COPD exacerbation, COPD related hospitalizations, cardiovascular events, and mortality. This is one of these studies. So we don't have RCT data, but in one study in which overlap syndrome patients were advised CPAP and the patients themselves divided them into two groups, those who were adherent and those who were non-adherent. The adherent patients had a much better 5-year survival compared to the non-adherent patients. Of course, this has limitations of the observational design, but then we also have data from much larger studies. So this is an insurance-based study from the US, and they studied the effect of PAP, the effect of starting PAP therapy on the hospital resource use, and they found that those patients, compared to the year before PAP, those patients who were adherent to PAP had lower emergency visits as compared to those who were non-adherent for 2 years, year 1 and year 2. And they also had lower rate of hospitalization. Those who were adherent had lower rate of hospitalization. Those who were non-adherent had higher rate of hospitalization. So now again, you ask me which one, BPAP or CPAP. As I mentioned, CPAP is the first line modality if OSA is predominant. BPAP, however, one pilot randomized study has compared CPAP and BPAP in patients with hypoventilation syndromes, and this study included OSA COPD overlap also, and they found that among patients with pre-existing hypercapnia suggestive of hypoventilation, BPAP is superior, as BPAP showed a greater efficacy in reducing CO2. So in a patient of COPD without hypoventilation, maybe CPAP might work, but in a patient of COPD who has coexistent hypoventilation, usually you may have to treat them with a BPAP only. And there is one very important caveat while using BPAP, particularly in a patient with emphysema. So in a patient who has predominant emphysema phenotype, these patients tend to have something we know as air trapping, or they have the phenomenon of autopeep. So at the end of expiration, they have a positive end expiratory pressure. To overcome that, a low level of EPAP helps in overcoming this autopeep. But if you apply an EPAP which is higher than the autopeep, that may actually worsen the hyperinflation. And in fact, that is what the studies have shown, that if the CPAP of 8 centimeter has shown to reduce hyperinflation in COPD, whereas a CPAP of 11 centimeter has shown to worsen lung function in overlap syndrome. So what this practically means is that if you prescribe a BPAP for a patient with OSA COPD overlap syndrome with hypoventilation and with a predominant emphysematous phenotype, then your EPAP level should be less than around 8, and then IPAP can be higher, and that may also help you in driving the ventilation and bringing down the CO2 levels. So now I'm coming to the end of my talk. So we have published this review article on the therapies of OSA COPD overlap syndrome, where we have proposed a phenotype guided approach to the management of these complex patients. So what we first look at is the daytime hypercapnia. If it is there, that is suggestive of hypoventilation. And then you look at the stop bang or the symptoms of OSA. If there are no symptoms of OSA, then it is likely this patient has primary COPD sleep-linked hypoventilation, because sleep-linked hypoventilation is always there in a patient who also has daytime hypoventilation, and these patients will then go for a predominant NIV therapy. Whereas those who have symptoms of OSA, you can do a polysomnography with CO2 titration. If they have predominant severe OSA, you may at times try a CPAP titration in them, but most of them will eventually require a BPAP therapy. Most of them will eventually go on to not be successful with CPAP titration and require a BPAP therapy. On the other hand, those patients who do not have daytime hypercapnia, in those patients, if they do not have any symptoms or signs suggestive of OSA, then you look at whether they have any complications of OSA, like pulmonary hypertension, diurnal hypoxemia, or borderline or nocturnal hypoxemia. If none of these is there, then you need not investigate these patients further for sleep disordered breathing. But if any of these features is there, then you go for a polysomnography, again preferably with a transcutaneous CO2 or an end-tidal CO2. And then if they have OSA, then you treat them as an overlap syndrome with predominant OSA. Again, no autopap in these patients. Why not autopap? Because autopap may not consider the unique considerations of autopeep as well as the requirements of BPAP in many of these patients. So an in-lab titration is necessary. And if there is no OSA, then OSA is unlikely in these patients. Just a word about other therapies. What if you have a patient of COPD with nocturnal hypoxemia? Why not just give them oxygen? Well, many people have thought about it, and many people have spent millions of dollars in conducting trials on this, like the INOX trial, the LOTT trial. And these trials have shown that when you give oxygen for a patient of COPD with predominant nocturnal hypoxemia, it does not work. In fact, as I mentioned earlier, those patients who had a high stop bank value in the LOTT trial and were prescribed oxygen for nocturnal hypoxemia actually had a higher mortality. So that suggests that this nocturnal hypoxemia in COPD patient may be a manifestation of sleep disordered breathing, which may be better responding to PAP therapy rather than pure oxygen. And we have written an editorial about this in the Indian Journal of Sleep Medicine, where we usually prescribe oxygen to patients with nocturnal hypoxemia only after treating their underlying sleep disordered breathing, which is leading to this nocturnal hypoxemia. Quick word about pharmacotherapy. Usually pharmacotherapy continues as it is for COPD, and the bronchodilators have shown to improve nocturnal oxygen saturation without improving the sleep quality. Whether the inhaled corticosteroids can lead to upper airway myopathy and actually worsen OSA, that is contentious, we don't know. And there is no significant studies of other respiratory stimulants in this population. So to conclude, sleep leads to changes in our respiratory function, which are harmless in a normal individual, but can lead to a complete spectrum of sleep disordered breathing in patients with COPD. And overlap syndrome results in worse outcomes in terms of quality of life and cardiovascular and survival outcomes compared to either disease alone. Diagnosis requires a high index of suspicion and in-lab polysomnography, preferably with CO2 monitoring. Observational studies have found benefit of PAP therapy. It has physiological basis and improvement in clinical outcomes, and a phenotype-based approach may help in choosing the appropriate PAP therapy in these patients. Thank you very much.